Now, transference is probably the most ubiquitous process going on in therapy all the time, and it's the most overlooked. It is the transference of attitudes from one's earlier childhood in significant relationships to the present situation, and especially in therapy, to see how it applies to the therapist. A transference hallucination in therapy has more clout than any other intervention that the therapist can make. Now, there's often a kind of covert stimulus on the part of the therapist that will elicit the transference. One could pick up transference most quickly and readily if one thinks that all references in therapy have to do with a therapist. Now, some trainees are reluctant to that. They think that's calling attention to themselves or being too self-centered. But actually, it is the way the process works. For instance, if a patient complains that the office seems cold, is this a reference to the therapist being distant at the moment? A patient said that his roommate seemed to be ignoring him and not paying attention to him. This alert resident was able to recognize in himself that he had, for that moment, had not followed his patient, and that the patient was actually responding to this stimulus from the therapist. A therapist had a preoccupying telephone call before his appointment with the next patient. When the patient came in, the patient had some kind of complaint about someone not paying attention to them or being too preoccupied. And actually, it was the therapist that he was referring to. Not that the patient recognizes this. They do not at all. They think they're talking about something else. But one could pick up on this kind of thing. But it takes a lot of practice in order to be able to do that.
Before you move on, how do you recommend therapists working with transference, especially when they're not in a long-term therapy situation?
How do they work with it?
How do you work with the transference to?
One says, could it be that when you say this room is cold, that you somehow picked up on something that I was doing that made you feel this way? And if they grant at least that's a possibility, and could we look at somewhere in the past where that seemed to be a big problem for you? And indeed, you do find out that one of the parents would readily be distracted, and that the patient was sensitive to this kind of thing. There is an old axiom in therapy that when the patient thinks of and talks about the present, the therapist should think of the past. When the patient talks about his past, the therapist should think, how does this apply to the present? The history that we take isn't simply to have something recorded for the record. It's to have something that's a reference back and forth from present to past. That's why I find that some residents seem unacquainted with the patient's past. They may have it in the computer or in the record about siblings or the parents' death or what they died of and so on. But this is not readily available in the resident's armamentarium in terms of information that he can make that connection. if I ask about siblings and he has to leaf through his record to find out, I know that he does not have that kind of thing available to him. So this moving back and forth from early significant relationship to the present time is how we understand and try to make a case for understanding why the patient can't finish his thesis or do other tasks that are completed.